All right. So it's my pleasure to introduce our next speaker, Dr. Hani Malone. And Hani and I actually overlapped quite a bit in our training. I trained at the Rush for residency and went to Columbia for fellowship, and Hani did the opposite. So we're basically the same.
Two sides of the same coin.
Yeah, but I think I'm just a little bit better surgeon, and Hani is maybe a little bit better looking. So it's evens out. That's funny how life works. So,
right,
happy to have him here to give us a talk on how to optimize surgical outcome in multi-level ACDFs.
Thanks, Lee. This is my first time here, and every meeting kind of has its own personality, and it's really been great. It's been very welcoming to my family. I had a ton of fun meeting some of our Chinese colleagues last night, and really a testament to UCSF that you can attract so many people that want to be a part of your community. So thanks for having me. Bobby Tay yesterday, I think, did a good job of explaining why anterior cervical approaches are pretty incredible, right? They outperform posterior approaches in almost every capacity outside of some select patients who are good candidates for laminoplasty. So we know that it works, and this talk will be trying to think about how you can maybe improve upon something that's already pretty good. I do have some disclosures, both ATEC and Orthofix who make ACDF implants, so real disclosures and real conflicts. Okay, so ACDF. It's extremely prevalent. It's one of the best operations we have. Until you really look it up, I maybe didn't realize how much it outpaced all of other cervical procedures. And this data is about 3 or 4 years old, so cervical arthroplasty has probably gained some traction. But ACDF is still far and above the most prevalent procedure. More than 100,000 cases performed in the U.S. each year compared to just a couple of thousand arthroplasties. And it's pretty equally distributed across the United States. I don't know if there's anybody from Rhode Island here, but they seem to really love ACDF. They do a ton of them. But other than that, it's pretty equally distributed across the United States. And that's because it works, right? Especially in the context of single or two-level disease. You have super high fusion rates. It gets a little bit more challenging as you move on to multi-level 3 and 4 segment disease cases. But you see improvements in disability, see improvements in pain and quality of life outcome scores pretty reliably. So it's a workhorse. It's one of the best things that we have. But there are still challenges. So you see non-unions, hardware failure, and adjacent segment disease. And so even though it works very well, obviously there's still room for improvement. I think it's a little bit of a focusing illusion because ACDF works well and it's a fairly straightforward procedure. And if you asked a surgeon in this room, like, hey, are you good at doing ACDFs? Like 100% of us are like, yeah, we're great ACDF surgeons. And so it's not the sexiest thing to sort of research and talk about at these meetings. You'll see a ton of talks about alignment and surgical planning, but not so much about ACDF. And it's not particularly sexy, right? It's just a plate and some screws. And it's not like an enabling technology ecosystem. Everybody has an ecosystem now, or AI or anything like that. And so it doesn't get a lot of publicity, but there are certainly ways that we can improve upon it. And given its prevalence, I think it's important that we continue to try to do so. So what are the challenges? Non-union, construct failure, adjacent segment disease is obviously sort of the big one, the holy grail. And then what are the components through which we can improve that? Well, decompression is sort of a separate entity. You have to do a good decompression, and biologics and alignment would sort of be their own separate talk. So today I'm really just going to focus on new innovations in plating and fixation, as well as interbody grafting. Obviously, ACDF has been around over 50 years, and some of the early implants are pretty interesting. I've had the great pleasure of trying to take some of these out. Not so much the cast bar plates, but I still see a lot of those Orion plates, which they really integrate and not fun to take out. But now, obviously, we've got much lower profile plates, much stronger, higher degrees of variability that we can use to place the screws. And so there was this transition from early rigid plates that were prone to loosening and breakage to more dynamic plates that allowed for some settling of the graft. We've got variable angle screws, lower profile, more versatile. We know that regardless of what plate or system you're using, that screw length matters. So if you get the screw more than 75% across a vertebral body diameter, that seems to have an important impact on rigidity and stiffness, which translates into better rates of fusion. And likewise, positioning of the plate matters. So if you can get the plate more than 5 millimeters away from the adjacent segment, that can reduce your ASD rate by about a third. So those things are really important. But we still have challenges even when you do those things right. And usually the failures in the multi-level context will present themselves in one of several ways. The one that most of us probably see most frequently is this distant segment failure, where you've got a long rigid plate, oftentimes with a locking screw at the bottom. A lot of the force gets transferred through that plate to that distal segment, and you see that pistoning effect where the plate sort of subsides and starts to migrate towards the adjacent segment. When you're using variable screws, oftentimes you'll see settling, and then the plate itself will start to migrate down towards the distal segment. So you see these kind of common patterns. I don't really see screw fracture or plate fractures that often, but that can occur as well, obviously. So there was this fad, I think, over the last 10 years to migrate towards multi-level zero profile implants. Obviously, they have a number of benefits. They're very easy to place. It's fast, less retractor time and so forth. And you get away from having that long, rigid plate that can lead to these biomechanical issues. And there have been a number of studies that look at it. It works in terms of fusion. The fusion rates seem to be pretty similar to traditional long plate ACDF in the multi-level context. The issue is with subsidence and alignment. So if you look at the major meta-analyses, and there are several now, the subsidence rates and then the resultant loss of lordosis, approaches like 50%. So these things will fuse, but they subside. And I just saw this patient like 2 days ago. It's a perfect example of that. She fused, but she subsided pretty good. And that has its own issues with alignment and adjacent segment disease. So segmental plating is this concept of placing individual plates, but in series as opposed to one long plate. And the concept would be that you have many of the benefits of traditional plate fixation, but without having that long, inert plate that can lead to some of those challenges with distal segment failure. And importantly, this is biomechanically different than these zero profile implants. So most of the zero profile implants will have integrated fixation. And part of the problem with them subsiding is that a lot of the force that's going through the interbody graft is then transmitted down through that distal integrated fixation and then sort of pistons into the vertebral body below. And so that's how they subside. And when you have a segmental plate where there's an actual different plate and it's not all being translated from the interbody through the fixation, then you can avoid that sort of biomechanical pitfall. There was for a while one or two vendors, but now there are multiple companies that make segmental plate fixation. So you don't have to be wed to a single vendor to employ this technique. It's definitely a regional thing, and this is kind of how I got interested in it. Because when I was in New York, when I was in Chicago for fellowship, I never saw it. It was just all traditional ACDF plating. And then I went to San Diego, where like people do anything, right? And I started to see it a lot with my partners, and I was like, that's kind of interesting. I've never really seen that before. Is there any data? And that's sort of what got me interested in pursuing it. And one of the concepts is rooted in adjacent segment disease. So obviously, when you've got a multi-level fusion, you're creating a long lever arm. And high school physics, torque is just related to the length of a lever arm times force. And if you have a longer lever arm, then you have more torque. And whether you use a single plate or multi-level plates, then the torque should be similar, right? The lever arm is getting longer. But there's another component of it, which is the rotational stiffness. So it's not just the length of the lever arm, but also the rotational stiffness of the lever arm. And so if you have an inert titanium plate, there's going to be more inherent stiffness than a biologically active fusion across multiple segments. At least that's the theory. And there's been quite a few finite element analysis studies that have looked at this. And I think you can only put so much stock in an FEA study, but they do produce pretty reliably the same conclusions, which is that the rigidity is generally better, particularly at the distal segment. And perhaps more importantly, when you do these FEA studies with a long plate, you generally see loosening, loss of fixation, loss of integrity at the distal segment. Whereas when you use segmental plates, they all sort of act independently. And so you don't have that highly vulnerable distal segment. I was a part of a finite element analysis recently where we looked at that and essentially came away with the same conclusion. So with traditional plating, maximum stresses and range of motions occurred at the distal level. It was a C4 to 7 model, so it happened at 6-7. But when you looked at the same FEA analysis with segmental plating, they all sort of behave similarly, suggesting that would kind of occur less of, or you'd have less of that distal segment failure. Also tried to look at it in other preclinical studies, so a sawbone and a cadaveric specimen, plotting some of these specimens and then putting them through sort of standard fatigue testing. And looking for loss of stability and fixation. And again, found sort of the same thing. So there wasn't a whole lot of difference in the proximal segments, but at that distal segment, the retention of stiffness was significantly higher in segmental plating as opposed to traditional long plate fixation. Not so much difference in flexion, extension, and lateral bending, but really in axial rotation. So what about clinical data? So like I said, when I came to San Diego 7 years ago, people were doing this with some frequency. So we started to collect our data just to look at it. At 1 year, we had 91 patients that had multi-level, so 2, 3, or 4 level surgeries. And so it was 22 levels, 91 patients. And at the end of the day, it's an ACDF, right? So they did well. You fix their radiculopathy, you fix their myelopathy. And so they had improvements in pain and NDI that were what you'd expect. No biological fractures or other issues. More importantly, from an alignment standpoint, the lordosis that was achieved seemed to be pretty consistent with traditional plate fixation. So you're not seeing that subsidence and loss of lordosis that you would see with zero profile implants. Got about 8 degrees regionally, 4 degrees segmentally, and then you'd lose some of that over the course of the year as the graft settled, but pretty similar to what you'd see with traditional ACDF plating. And then the fusion rate was pretty good. So 86%, you can argue whether or not that's good in 2025. But again, these are multi-level cases. And we were pretty, I would say, scrupulous when we were looking at the interspinous motion. Interestingly, for a lot of those folks that had interspinous motion that was like, 2.5 or 3, which we called pseudos, when you got the CT scans, they had a pretty solid bridge of bone. So I don't know if interspinous motion alone is a great way to look at pseudoarthrosis in these segmental cases, but very few takebacks for pseudos of those that did have more than an interspinous motion of 2. And importantly, there's really no relationship between the number of levels treated and pseudo risk. So when you go from 1 to 2 to 3 to 4 level ACDF, the risk of a pseudo increases disproportionately. It's not just that there are more levels that can pseudo, the actual likelihood increases disproportionately. And we didn't see that. So that was important. Subsidence rates were pretty consistent with traditional ACDF. So when you look at the meta-analyses of those multi-segment zero profile constructs, subsidence is approaching like 50%, where we saw it closer to 10, which is akin to what you'd see with a traditional long plate. So not all these implants are the same, and a lot of the second generation implants now are going to be slightly different. So some of the first gen, the plate was actually, the way it locked into the inner body is they were actually integrated. And so you'd see that similar phenomena of loading through the implant that would go then into the plate and cause subsidence. Most of the second generations now divorce the implant from the plate, so you don't see that sort of integration that leads to subsidence. And then, I think the most interesting question would be adjacent segment disease. How does this impact adjacent segment disease? Does it have a real outcome? Obviously, at a year, you really can't make any comments about that. But hopefully, we'll get more data and we'll be able to comment on that in the years to come. So, not the end-all, be-all. You can't use it if somebody's got spondylolisthesis or if you need to pull the vertebra to the plate to get an alignment. But for a standard gen case, it's not a bad option and seems to have some potential benefits. So, moving to grafting. Doing okay on time. So obviously this is what we all kind of grew up with, right? Allograft spacers. And in intervening decades, we've seen a lot of innovation from these allograft spacers to then hydrophobic smooth PEEK, which obviously pseudos, and then titanium, which is great, but it's too stiff. And then we had titanium coated PEEK, which delaminates. And then we started to get better ways to coat PEEK with titanium. And then we started to 3D print titanium. And then we started to get really bioactive 3D printed titanium with porosity and better bioactive implants. So a lot of progress has been made, and all of us here have been here to see it. But we still have these challenges, particularly in the context of multi-level disease. We're seeing relatively high pseudo rates, 20, 15% at 3 and 4 levels. If you want to cut down on that, obviously you can do a front back, but we all know the morbidity of going in the back and opening the posterior muscular envelope. You'll often see these distal segment failures as you do here. This is a patient of mine that had rheumatoid and just failed terribly and quickly. So what's left to do in interbody space, right? We've already got TI with porosity with a good modulus. We've got wider, deeper implants, and they come in multiple lordotic options now. So a lot of progress has been made, and what's left? Well, one thing that I think not a lot of emphasis has been placed on is actually the morphology of the cervical interbody and not taking advantage of the uncovertebral joint. So when you place a square implant, you're leaving sort of a lot of meat on the bone in terms of strong cortical bone that's in the uncovertebral joint, and you can see that here. So there are a couple of different companies now that have started to expand their interbody spacers into the uncovertebral joint. I don't have clinical experience with the two on the left. The one on the far right is the one I have experience with. Is actually far more aggressive than the other two. So it's about a 16 millimeter implant. and then has an 11 millimeter extension, so 5.5 on each side going into the uncovertebral joint. So the smallest size is 29 millimeters. That's really wide. So surface area alone obviously confers some benefit there, but also you're grabbing that strong cortical bone. In addition to these implants, there's also patient-specific implants, which have been recently FDA cleared. I don't believe these have actually been implanted in any humans yet. I think that's just starting, but another interesting concept where not only can you get out into the uncovertebral joint, but you can actually capture a patient's specific anatomy. And it's hard to imagine that that's not going to be optimal, but the cost issue is going to be prohibitive for the majority of our degen cases. So the elephant in the room when you're thinking about placing a graft that goes all the way to the tip of the uncovertebral joint is safety. And obviously, if you're placing a small spacer in the middle, you don't have to worry about it because you're way away from the tips of the uncovertebral joint. But when you're placing a spacer like this, and the vertebral arteries loom large. And so I think there's a fair amount of reticence to pursue this because of that safety issue, which obviously, I mean, you take out a vert and a one-level ACDF, I mean, you might as well hang it up then. So a lot of thought and work went into how you could do this safely. And I think from the industry side, they really wanted to emphasize on this thing called the peak-to-peak distance. So looking at basically the length from one uncovertebral joint peak to the other. And if that was wide enough, then the graft would work. And part of that was just trying to think, will the graft actually fit in these uncovertebral joints? And if they're too degenerated, maybe we shouldn't even attempt it. So that's kind of how I thought about it for the first couple of cases. But I think I've done like 60 or 70 now. And I really don't worry about the uncovertebral joint anymore. I just worry about the vertebral arteries. And so I figure out where the wing tips will be. And as long as it's 30 millimeters or more, then I feel comfortable that I'm not going to even flirt with the vertebral artery. And so early clinical data at our institution and one other, we started to look at patients. And basically inclusion criteria was just that they had a distance between their vertebral arteries greater than 29 millimeters, looked at complications, and then just basic outcomes. So 34 patients that are at a year so far, 48 levels with these expanded implants, and then 15 internal controls. So a small number of internal controls, but it's nice because it's the same biology. Now, importantly, no vert injuries, no episodes of foraminal encroachment. That was a concern. It does take like an extra 5 minutes, but not a whole lot of extra time. And we definitely saw improvements in terms of subsidence. So the loss of central disc height at a year is like 0.5 millimeter. And only one case subsided. It's like 2% subsidence, much, much better than like the segmental data I just presented, for example. And in those internal controls, we actually saw quite a bit of difference. So about 1.7 millimeters on average and about 26% subsidence rate. So, I mean, it stands to reason if you have an implant that's wide, it's going to subside less, and particularly if you're grabbing that cortical bone. Fusion rates were pretty good, 8%. So, nothing crazy, but certainly better than, say, that other data that I presented from the segmental cohort. In terms of technically doing it, it's not particularly complicated. I think if you do disc arthroplasty, you're probably familiar with preparing the disc space in a way that maintains its virgin morphology and getting out into the uncovertebral joint. You can take like the posterior third of the uncinate off. So obviously, if you need to do a good foraminotomy, like you have to shave down some of that posterior uncinate bone, and you can do that. You just need to maintain like the proximal or the superficial 2/3 of the uncinate so that it fits well. And then usually before I take down the PLL, I'll get the rasp in there and really sort of clean out the space to make sure that the implant's going to fit. And that way I know that I'm not shoving any, material into the foramen when I'm rasping and kind of clean the space out. And then the implant really finds its rail. So it wants to go in that space because you sort of created a channel using that rasp. So when we first started thinking about this, or when they started thinking about this and I sort of jumped on the bandwagon, we thought cases like this you couldn't do because the uncovertebral joint was so spondylitic and it wouldn't accept the implant. And the reality is you put a little bit of distraction on there and just do a little bit of carpentry, you can actually get it to fit quite well. So you can get a diamond tip drill or what have you and just kind of recreate that space. The cortical bone is still there and it's still strong. So, it maybe take a minute or two, but you can certainly do that. I found that I feel like I'm much better at getting foraminal decompression now that I've been going all the way out in the uncinate. It sort of opened my eyes a little bit. So just a few case examples to stay on time here. So rheumatoid patient, I showed you this patient that failed before. 2 levels at the bottom were large enough to fit that large graft. And you can see that she did well here, even immediate post-op and 8 months out. She's not at a year yet, but looking pretty good for a patient on chronic steroids with not great bone. This is a buddy of Joe and I's who had this ridiculous construct placed by the the surgeon of the Washington Redskins, and he failed. But because he failed, the bone in the inner space was all eaten away, and there wasn't a lot of cortical bone left there for grafting. And so by placing this graft in place, you could kind of get out into the wings and still grab some of that strong cortical bone. Here's his post-op scan. Obviously, that looks good. He broke a screw at a year, so it's not perfect. But it certainly seemed like it was going to be helpful at that time. But he ended up pseudoing at 5, 6, so it's not perfect. But it's safe. There's promising early data, particularly on subsidence. I think it's really good for a revision if somebody's got a pseudo or a failed CDR where there's a lot of osteolysis in the normal disc space between the uncinates. It's also, I think, a really good anchor distal segment of a multi-level ACDF. So ACDF is effective. It's a workhorse. I think segmental plating confers some benefits, better than the zero profile constructs. We need more long-term follow-up. Cost is always a thought, right? There's more screws, there's more plates, there's more cost. And then I think for revisions, for multi-level ACDF and for pseudos, expanding implants into the uncovertebral joint holds real promise. And it can be done safely if you're just thoughtful about it and really look at the vertebral arteries. Okay, thank you.
Oh, that was a great talk, Annie. And I disagree with you with your statement that, ACDF, this talk is not important. I think it's actually probably more important than like some of the more complex cases we do because it's so prevalent, right? And it's like relevant to everybody's practice here who treats cervical spine disease. We looked at our 3-level series at UCSF, and what we found, is that the middle level actually heals fastest because it's stretched, it's shielded, and then followed by the top level. The bottom level always takes the longest, as you said. Depends on, the carpentry and the patient biology. A lot of times it subsides, or if you use the allograft, or, iliac crest, frozen iliac crest, some of it resorbs because it takes so long to fuse, and then you lose the height and you end up with a pseudo. Don't do a lot 4 levels, but when I do use the multi-level plate, 2 above and 2 below. I want to see if that actually makes a difference. So in your experience, the fusion does improve with the segmental plate.
So the fusion rates, I think, are pretty similar, to be frank, across whether it's segmental, zero profile, or multi-level. I think the difference is that you don't see that disproportionate risk at the distal segment. And when they do, so all the segments kind of act individually. And there's not a huge difference between it being the distal segment or the proximal segment or the intermediate segment because there's not that same stress shielding phenomena. And then likewise, when they do fail, you're not presented with the same sort of biomechanical catastrophe where you've got a plate that's already at the level below. It's just more like a traditional pseudo. And obviously, if you need to revise that pseudo, it's easier as well. So the real benefit is you're kind of getting the benefits of the 0P phenomena, those purely integrated implants, but without the increase in subsidence and loss of lordosis. But I think it's difficult to make the argument that they're fusion at a higher rate. And if that were the case, it would probably only be significantly different at that distal segment.
Bobby.
Hey, Bobby.
I think try to do when that eventual next level wears out, which it will wear out, on all of us. The revision of the extension is so much easier.
Yeah.
Right, because you don't have to go and take the whole plate out, or you're locked in doing a 0P, or you're locked in doing a front and back. Right.
And you put a 0P below a 3-level plate. I mean,
that's going to subside, or even above. It's like it just had a hard time with those. So it's a great idea. The question is, do you ever do a short plate, longer plate in between, and then a segmental plate above and below, just to plan for the next level wearing out and making it easier? Or do you think that there's a biomechanical disadvantage doing a mix and match of plating?
So I'm not sure. I've not studied it. To that point, sometimes what I'll do, like say somebody's got a slip or something like that, and you really need to have a rigid plate that you can pull the vertebral bodies to create the curve. Like say it's a 4-level, I'll do like a 3-level traditional plate, and then I'll just put a segmental above it, just so I can kind of get in and out of 3-4 quickly. But that's an interesting thought, and probably something that deserves some study.
Longer plate to improve your lordosis in the mid portion of the cervical spine, and then use your other segments to help you.
Let's check it out. I think it's a good idea. Yeah, I hadn't thought about that in that way.
Great talk.
Hey, Emil.
Sorry, I'll give it back to you, Shane. Question about the last device you showed.
Yeah.
Do you think there's a confounding factor that because the device is making you go to uncovertebral joint, you are basically doing a more thorough disc prep, decorticating that? So if you put a similar, like what's that level? Like the top 2 level is not making you go out there. But if you did the same work, but you put the smaller implant, would do you think it would have an impact?
There's probably something to that. I mean, there's probably something to that. Like say I did the same width of an ACDF, but then I just put like DBM fibers or something out there instead of a graft. But I do think that there's, I mean, you don't have to like convince yourself that if you've got a 27 millimeter graft and it's going all the way out to that cortical bone, I'm sure there is some structural improvement. There are no finite element analyses or anything like that or preclinical biomechanical testing that can give you like quantitative data to support that. But sure, I think that there is, and what I will tell you is I think that there is like a confounder in terms of the foraminal decompression, because when you get way out there, I mean, you see the nerve exiting out, and I think you do a much more thorough decompression. Joe's going to give me a hard time because his buddy sued out and he's got to see him at soccer practice.
I definitely believe that covering that incident makes a big difference. I was able to place those patient-specific implants on Monday.
Oh, you were? So you were like the first?
I was the first one, yeah.
So and that's a very cool idea. I mean, because it's not just getting way out there, but it's also conforming to the morphology. So did it go well? It's probably like the first one in the country.
I was. It was. I did 3 cases that day, and they all. And I had my chief resident, put a couple in. Just seeing someone who's never used it before, and really, when you have those guardrails, it just slips perfectly right in. But I can certainly believe that the subsidence rate is going to definitely change because you're capturing all that really hard bone. What I wonder, because you made a comment about because I played a lot and I've definitely drank the segmental plating Kool-Aid. I wonder if we have a difference in implants like this, could we then go back to using interfixated screws with these and maybe work our way from plating because the subsidence is going to be less because we're covering a larger surface area?
100%. Like, I mean, I feel a lot more comfortable putting in a traditional plate if I've got a really good anchor at the base, like that 4 level I showed you where I had the 2 extended uncomfortable implants. I mean, I don't know how you guys feel about I've used some of these patient-specific implants really in the context of ALIF, like to deal with like an obliquity, kind of to Praveen's talk about trying to deal with some of those coronal issues in an MIS way. And they've worked like amazing. So I'm like a full believer. The only issue is cost. And can we get to a place where the cost comes down enough for us to use this in like traditional degens? Because if I needed an ACDF, like I would have one of these, like no question. Yeah. But it's so expensive. All right, great. Have a great meeting, guys.